World Cup represents one of the largest recurring mass gatherings in the world, bringing large groups of international visitors, dense crowd environments, increased demands of the public health infrastructure. For emergency physicians, hospital leaders, EMS, and public health practitioners, this is not simply a sporting event. It's a challenge that's best met with a multidisciplinary response. From respiratory pathogens and gastrointestinal syndrome to vector-borne illness and high-consequence infectious disease, travel-associated disease, importation, the operational implications are significant and challenging. And today we're going to examine relevant infectious disease threats, learning to strengthen situational awareness and discuss ways to enhance timely response in partnership with public health. The objectives today are to develop a community of practice in the Southeast states, recognize the most likely and high impact infectious disease threats anticipated during World Cup 2026, and understand actionable strategies to strengthen surveillance, situational awareness, implement infection prevention practice, and enhance multidisciplinary collaboration. Next slide. Today, we've invited multiple expert panelists from across our region to join the session. After our speakers present, the panelists will help us engage in robust discussion. Our goal is to offer a great learning opportunity for everyone that's participating as a practice partner in HHS Region 4. And very quickly, I want to introduce our expert panelists who are joining. Armand Akri is the Grady EMS District Manager and leads the Grady EMS Biosafety Transport Team in Atlanta. Brooke Brewer is the Program Manager, Infection Prevention with the Special Pathogens Response Center, Regional Special Pathogens Treatment Center at UNC Health. Dr. Esther Wong is the Associate Medical Director for the Emory Grady EMS Biosafety Transport Team and Medical Director for AMR DeKalb County, and on faculty at the University School of Medicine. Ken Kick is the Community Health and Medical Operations Manager for the Kentucky Department of Public Health and the State of Kentucky's Healthcare Coalition State Program Director. Dr. Kumar is the Medical Director for Grady EMS and an Associate Professor at the Emory School of Medicine. Paula Hoyle is a Nurse Educator for Infection Prevention with the Special Pathogens Response Center at UNC Health. And Sharon Carrasco is the Director for the Regional Emerging Special Pathogens Treatment Center at Emory and the Director of Education and Training for the National Emerging Special Pathogens Training and Education Center, or NETEC. Welcome to you all. Thank you for joining this session. Before we transition to our speakers, I want to start with a quick poll to maybe get everybody's sort of baseline familiarity with today's topic. Stephanie will bring up that poll now. The poll is anonymous. I encourage you to fill it out, and we'll share the results as soon as the feedback slows to getting the numbers of responses up. All right, as is typical, as the responses are coming in, it looks like we're trending to slight knowledge to moderate knowledge, with a few very knowledgeable and extremely knowledgeable. And if anything, these session polls actually kind of validate the sampling, because we always get a bell-shaped curve here, which is great. All right, I think we're ready to share those results. The vast majority of participants here are slightly knowledgeable or moderately knowledgeable about the topic. So with that, I'm going to introduce our speakers. Again, thanks so much. Next slide, please, Stephanie. Thanks so much for joining us today. Dr. Gavin Harris is the Director of Education and Research for Emory University's Serious Communicable Diseases Program. He's also the co-principal lead for our ECHO for Region 4 Readiness program. He's a professor in the Department of Medicine and Critical Care at Emory University School of Medicine. Dr. Pavlik is the Epidemiology Preparedness Director with the Georgia Department of Public Health. Warm welcome to both of you. Thank you for speaking. Next slide. Who's our first speaker?
I think that's me, Dr. Isakoff. Thank you.
Go for it.
All right, I will go for it. And I just want to apologize for the audience who wasn't aware Dr. Pavlik and I were not aware we were going to be part of such an illustrious panel. So we had previously prepared about, I think, 822 slides, but we will cut it down to a little bit. So in any case, again, thank you so much for having me. It's really an honor to talk about all this, as we've been involved in preparation with these infectious diseases and with the World Cup for some time. So I'm going to move relatively quickly in this first section here. And some of this is adapted from threat assessments that we have done at the Emory SCDP over the past several months, if not years. But 2026, I think, is quite unique, especially in Georgia, especially in Region 4, for a variety of reasons that are both political, geographical and also environmental. In Atlanta, we certainly are at a global nexus for many different reasons, and including things like mosquito vectors. There's variable immunization coverages across parts of our region, communities. We have also a very dense network of healthcare facilities and systems. So today I'm going to walk through some specific infectious threats that are related to not only just mass gatherings, but also with the World Cup. And I do that with a disclaimer, which is we will be talking about a lot of things that may come from somewhere else, but I just want us to be aware that things don't have to come from somewhere else. And so things may pop up in our own backyard, and it's really important to be very attuned to signs, symptoms, and exposures. So with that, why don't we just jump in then? Next slide, please. This is a list. I'm sure some of you have seen something like this. These are the countries that are coming to Region 4 or who have already arrived in Region 4 for the World Cup specifically. And we think about high consequence infectious diseases that can stem from those countries. Again, this is not an all-inclusive list, but as you'll notice with those diseases on the right-hand side of the screen, we have seen outbreaks of a lot of these, if not all of these, in the past several years, and some of them, of course, are ongoing right now. A lot of these diseases, I just want to also point out, are not spread easily, and they're not spread rapidly, through the air or something like that as well, too. So just some things to keep in mind. But again, common things being common, most of those common things are not actually on this list. I did also want to point out Uruguay down there at the bottom. You can see Andes virus. We had thought about Andes virus for some time prior to the current outbreak or the most recent outbreak that has occurred. So it's just, we have to be careful, I think, when we think about these diseases. Next slide, please. What I also want to point out here is that the probability of something happening does not always equal the consequence, right? And so, as you can see here, some risks for some of these illnesses may be quite low, but the operational impacts can be quite variable. And even if we think about something that is not on this list, like Candida auris, right? This is becoming a huge problem throughout healthcare systems in the United States. And that you might even argue could be more of a disruption to a healthcare facility in the long term than something like a viral hemorrhagic fever. You'll also note too that things like measles, arboviruses, right, moderate to high impacts can be spread quite rapidly, but the strain on the healthcare system may not be as high as one might think. Next slide, please. I'm not going to go through the entire situation of or the entire track of our most recent Andes virus outbreak that occurred on that international cruise ship. So next slide, please. But to end up where we are, just to kind of summarize and give a situational, report. So in sum, we've had 13 cases total, 11 have been confirmed, 2 probable, stretched over several continents, multiple countries. But importantly, there have been no positive patients in the United States. And I think this is really incredibly important for everyone to understand. Monitoring, of course, is continuing. There are patients who are being monitored at home throughout our country. And there are also, of course, passengers, I should say, not patients, passengers, some of whom are still under quarantine at the National Quarantine Unit. I believe there's actually one person who is still there too. Now, Andes virus really happens a lot more frequently than we might think. It's only recently been elucidated as a potential pathogen here of concern. Next slide, please. The important thing with Andes virus, it has a very long incubation period. It is the only species that we know of hantavirus to be spread person to person. But I will point out that there is a Buenos Aires phenotype, which is a variant of Andes virus that has also been suspected to be spread person to person. But phenotypically, it is truly the same as Andes virus itself. And Andes virus is named for the Andes Mountains. It was discovered in the 1990s, I believe 1995, in the mountains of Argentina by the same team that actually discovered the Sin Nombre hantavirus that was a result of the Four Corners outbreak just the year before. Treatment for this is largely supportive. Next slide, please. Another illness I think we should be aware of, moderate, I think, risk of us seeing this in Region 4, especially with the World Cup, is Lassa fever. So this is a viral hemorrhagic fever that, has really had continuous outbreaks in the Nigeria and surrounding countries for the past decade or so. And unfortunately, these outbreaks continue to increase in severity. If you'll notice that case fatality rate from this year is much higher than it was last year. And a lot of this has to do with the fact that patients present later in their courses of illness. There's a lot of challenges with education. There's a challenge with healthcare seeking behaviors, a lot of distrust of the medical system, challenges with personal protective equipment and supply chains. And so there's a lot of healthcare worker infections. It's very concerning, of course. And what's also, I think, important to think about too is the demographic that's mostly affected seems to be a 21 to 30 age group, the demographic that we might think of as usually the healthiest, the most strong, and sometimes even the most well-educated. Definitely challenges to think about. And also with all of these viral hemorrhagic fevers, for the large majority of them, there's no pathognomonic signs that are easily elucidated when patients might arrive or when there's clinical suspicion. Next slide, please. Crimean Congo hemorrhagic fever. This is also something that we've been monitoring, and there have been sporadic outbreaks really throughout the world, vastly beyond the original regions in which it was discovered in the Crimea in Eastern Europe, and then also in the area of the Congo River. So there have been dramatic increases, especially in Afghanistan, Iraq as well recently. Likely low risk, but still with the potential for significantly high impact. This is spread through ticks and domesticated animals, and we see increases in these during the times of animal slaughter, holidays, and things of that nature too. So really, April through October is a pretty big peak season for something like Crimean Congo hemorrhagic fever. But the other thing is, tick populations in general throughout the world are spreading as the climate changes. And so, ticks that have, even in this country, that carry Lyme disease are spreading northward and even southward beyond their usual traditional ranges. We've also seen things like the Asian longhorn tick, which carries Japanese encephalitis, show up here in the United States. Not the disease, but the tick that has the potential for carrying this disease. And so as air travel increases, as shipping lanes certainly spread, you think about how it's not very in the distant future that we might see some more cases of things like Crimean Congo or hemorrhagic fever. Next slide, please. Of course, no talk is complete about viral hemorrhagic fevers without current outbreaks that we have in the world. And I know we've all been following the Bundibugyo Ebola virus outbreak in the northeastern part of the Democratic Republic of Congo. What's interesting and a bit concerning is, these numbers are changing rapidly. And so we don't fully understand yet the scale of this outbreak. It has spread, of course, to Uganda, and there are even more suspected cases than what I've listed even in these slides too. But this outbreak was likely spreading for some time prior to detection. And while traditionally Bundibugyo outbreaks have been less severe than those of the more common Ebola virus species such as Zaire or Sudan virus, when you have an undetected spread for long periods of time, everything is struggling to catch up. And this is a region that has tremendously porous bores. This is known as the African Great Lakes region. It's a very politically unstable region with Rwanda, the Democratic Republic of Congo, and then, as you can see, South Sudan, which has, of course, had its own challenges in recent years as well. There's a lot of difficulty in getting aid into these regions. There's a lot of armed militant groups that are controlling specific cities. And so it's a really challenging situation at the time that, again, I don't think we fully understand the true extent of this outbreak. At the bottom, you can see 5 Ebola treatment units are currently being established. This number has actually doubled in the past week or so, and there's well more than 80 patients. So again, things are changing. I'm not sure it's necessary to think about the exact numbers. We do expect these case counts to increase. And I will just say, though, that the risk of Ebola coming into this country as a result of the World Cup is actually quite low, given political situations that have developed on our side of the Atlantic Ocean with travel ban screenings and things of that nature as well. But that does not mean that we may not see cases of this disease in the future, whether that's through repatriation or whether that's through travelers who have come through other countries as well, too. Okay, next slide. Thank you. The other VHF I did want to bring up as well is we've had some sporadic cases even recently, one of which is a patient who remains critically ill in an ICU in Saudi Arabia, is that of MERS, Middle East Respiratory Syndrome, traditionally thought of as a disease that is only spread through contact with dromedary camels. These are the one-humped camels, but actually we've found cases recently in the last year or so of people who have gotten this illness without having any sort of exposure to camels or camel products. Now, the majority of cases are asymptomatic. This is a concern, of course, with the World Cup, given that the team from Saudi Arabia is here. Fans have also been allowed to travel as well, too. And so it's just something, of course, to keep in mind. Patients typically present with respiratory symptoms such as pneumonia, acutely worsening, and sometimes, unfortunately, end up with requiring mechanical ventilation. Next slide, please. Influenza viruses, I felt it important to mention, as we've seen a lot of influenza outside of the traditional seasonal variations that we typically think of, especially in the Southern Hemisphere. Japan currently has been experiencing a dual peak season with influenza-like illnesses. Of course, we all think about H5N1 and avian influenzas, but for sustained transmission, the risk is really low, though we are, of course, seeing it throughout multiple species in the world. I'll also point out too, influenza D virus, which is not something we typically think about, poses a lot of risk to cattle. And I know with the New World screwworm outbreaks in Texas, we certainly are worried about the domestic animal supply. But influenza D is interesting too, because there have been some antibodies discovered in humans, which certainly predisposes us to exposure, but also there have been attributes that have led us to believe that it has the possibility to mutate and potentially jump species into humans as well too, and cause significant disease. It's been a pretty severe influenza season in the United States throughout. We haven't had many cases at the moment, but we are certainly have seen cases in the summer as well. And as patients and people come from different areas of the world, Southern Hemisphere and Asia as well, we do expect to see an increase in respiratory pathogens. Next slide, please. Now, why does 2026 matter for measles? Well, this is a huge topic. We've had declining immunization rates nationwide. Unfortunately, it does appear that we are on track to lose our status of eradication that we have held for decades here in the United States from the Pan American Health Organization. And as of the 12th of June, as you can see, we've had significant outbreaks. This number is also outdated as there have been additional outbreaks that have been spotted and have popped up. So things continue to change rapidly. And I think one of the reasons for this is there's challenges in reporting policies in county to county, state to state, and even at the level of the federal government. So there's likely an underreporting. Physicians are not very comfortable, I'm going to be honest, in general, diagnosing this condition because it's not common, thanks to the fantastic immunization practices that we've employed over decades or so. And so there's often a misdiagnosis, a delayed diagnosis as well, too. And then surveillance has also been quite challenging for measles itself. So, in Georgia, we, of course, have had several cases of measles, and it does have the potential to have high impact. This is a disease that is spread very easily and is considered one of the most, if not the most contagious disease that we know of to humankind. One person has the potential to spread it to 20 secondary contacts. So very important illness here. We do expect to see cases of measles, I'm going to be honest, as a result of the World Cup, just with the thousands of people who are gathered here in the region. Next slide, please. And then, of course, we have our other arboviral diseases, right? They are carried by mosquitoes, so dengue, chikungunya, Zika. I mentioned this. We've had increased cases in the Caribbean, in the Western Hemisphere throughout the past several years as well. And a lot of these symptoms are sometimes indistinguishable from some of the viral hemorrhagic fevers, from common, other viruses that we might have, in this country and populace. So, treatment is largely supportive for these kinds of conditions, but heightened level of alert is, as a lot of these are unfortunately going to become endemic in the United States themselves, especially in the next several years too. So I just went through a lot, and I do apologize, but I want to make sure we have time for robust discussion. So with that introduction, I'm going to turn it over to my colleague, Dr. Pavlik.
Hi, good afternoon. So with all of that information about all of our diseases, our goal is really for early detection of unusual activity before widespread transmission. So we have the capability to do this through a wide variety of surveillance strategies, including our syndromic surveillance, which identifies kind of syndrome-based information for patients who present to our emergency departments and urgent care facilities. We utilize laboratory surveillance, of course, our healthcare reporting, some environmental monitoring, which I'll touch on, as well as some potential like federal intelligence sharing as well. Next slide. So really, we can't do this without, leveraging both our healthcare and public health expertise. Our goal here is to protect our visitors, our residents, and healthcare workers during World Cup. And we do this, again, through that statewide disease surveillance, through epidemiologic investigations, all of our emergency preparedness and response actions, our healthcare coordination, and partnering with our healthcare partners who really have the clinical expertise for high consequence infectious diseases, have that preparedness training, infection prevention guidance, as well as, our regional treatment and assessment capabilities. Next slide. So as I briefly mentioned, some of our environmental monitoring, I just wanted to touch on, a program that we have that we do enhance during World Cup, which is our BioWatch program. This is an air monitoring system that detects the presence of select biologic agents. And it's really a collaboration among all levels of our government to support, both public health and emergency management communities to be able to prepare for and respond to a biological incident. It is a federal program. However, it's locally operated here in Georgia and many other states and federally managed. Next slide. So why do we do air monitoring? It's really because it provides us that capability for early detection, which means early treatment and ability to save lives. Standardly, it may be multiple days. It could be up to 6 days before we actually have clinical detection of a biological agent. However, with BioWatch, we're able to detect that biologic agent through air monitoring within the first 1 to 2 days after it could be released into the environment. Next slide. And this program is really only possible because of our BioWatch Advisory Committee, which brings together all of these federal, state, and local partnerships so that we are prepared for and able to respond quickly. Next slide. So we utilize all of this information to help us identify what's our threat response framework. We have that ability to look at, again, that BioWatch alert, our clinical case detections, laboratory findings, any syndromic surveillance anomalies. So are we seeing an increase in gastrointestinal illness or an increase in fever and rash that's presenting to our emergency departments? And it allows us to then respond appropriately. We're able to verify diagnosis with laboratory testing, initiate epidemiologic investigation, conduct a risk assessment, provide that public communication if an exposure occurs, and then kind of go into that multi-agency coordination for response. Next slide. And I don't think I could ever get on any call and not just remind about identify, isolate, and inform, and the importance of thinking about when patients present to emergency departments, urgent cares, any facilities, and have travel to an area that we just spoke about that could be of concern. They've had a risk factor where they've had a contact to someone who may be sick, again, that travel, and they have the clinical picture that could describe one of these pathogens that we're talking about. And then the importance of quickly isolating them and informing, both your internal process as well as, the state public health agency. For Georgia, of course, it's 1-866 Pub Health, where you can get to a medical epidemiologist 24/7. Next slide. So I think with this, we're going to go into a few scenarios. So I'll turn it back over to Dr. Harris to start us through, and we're going to kind of walk through this with some of our panelists as well.
Thank you so much. Yes, so we're going to put some of our panelists on the spot here. Going to have a few scenarios based on things that we've just discussed, and I think it'd be helpful to elucidate thinking behind how we've worked through these problems. So I'm going to read the first scenario. We have a 34-year-old international traveler who arrives in Atlanta for a World Cup match. 2 days after arrival, 2 days later, they present to a local emergency department with a fever of 102 degrees Fahrenheit, cough, conjunctivitis, and a generalized rash. The triage at that local emergency room, the note does indicate recent travel through multiple international airports, as well as attendance at crowded fan events, and we can presume those to either be games and or fan fest-like activities. Next slide, please. And I'm going to call on Dr. Kumar to kind of start us off with this discussion, just because she is next up on my screen. If we could click through, please. So one of the questions we have is, what is the most important clue in this specific scenario that we talked about? What stands out to you, and how might you think through the first identification piece of this?
Well, I think fever and rash are very generalized symptoms, right? But I think the combination of travel history with the symptoms is what is concerning. It depends on the travel history, I would say.
Excellent. And with things like rash, what is something that might be, of high concern or high alert from your standpoint?
I think it depends on the travel history, where they are, and I would definitely, utilize DPH resources to look up what's going on in those regions. Jessica was kind enough to send us links, which was great. But in this case, I mean, they have fever, rash. It depends on the distribution of rash. Do they have something like measles? Mpox, I guess. I'm just throwing things out there at this point, not knowing where they were or what they were doing.
Yeah, fantastic. I know we've distinctly or specifically left this a bit broad to think about that as well too. So, say there was a concern for measles in this case, right? What would be our steps, and how might you think about this, from an identification, isolate, and informing piece? So they had a rash that was consistent with measles.
So, I mean, I think the biggest concern is to make sure we educate our emergency departments or EMS agencies, right, to ask for that travel history at initial contact so that we can continue to protect. I think it's a little bit easier in the emergency department, so to speak, because they approach the desk and the first thing you ask is for symptoms as well as the travel history. In EMS, we don't often get a good heads up necessarily as to what we are walking into, but I think that just-in-time training and the importance of explaining that we have to get these questions in upfront to protect every other point in the back end that might come into contact with this patient is important before we decide what's going on.
Excellent. Jessica, anything you'd like to add? No, thank you, Dr. Kumar. Sorry for putting you on the spot there.
Didn't know that this was going to be a pop quiz. I did. Alex did not give me that heads up when I signed up.
She's never going to join again.
No, that's it. One and done.
No, I think you're absolutely correct. Thinking about that travel history, the clinical picture of this particular patient, of course, vaccination history, which may not be as easily accessible if they're an international visitor, but at least asking those questions about, knowledge of previous vaccination can be important to help us guide kind of some of those next steps as well.
Yes, Sharon, I see your hand up.
Yeah, sorry. And maybe you're going to get to this, Dr. Harris, so I don't want to steal your thunder or future slide, but just to follow up to Dr. Kumar, just adding that, regardless of the pathogen, if somebody presents to your point of entry and they're symptomatic with any of those symptoms that you've identified, one of the first things you should be doing is asking the individual to put on a mask. So again, whether it's one of those scary pathogens that you went through early on in the presentation, or if it's something that is within our community, we want to stop that source where it is. And so one way of doing that is to mask that individual while you kind of understand that travel history, and you kind of get more into that risk, and understand what potentially this could be, but masking immediately upon identifying those symptoms.
Those are fantastic points, and yes, we will get to that. But thank you very much for making that first and foremost. Next slide, please. And I just wanted to point out here too that there are many different points of interaction and interfaces where there are opportunities for uncovering and to think about potential pathogens and histories that patients may have, right? So there, of course, are points of entry. There's the triage screening, the importance of obtaining that travel history in conjunction, I will say, with symptom exposure and symptomatology. Right, there's the combination of symptoms or the constellation of signs and symptoms that can certainly alert us to concerns for specific pathogens. There also might be infection prevention alerts that come through from either healthcare facilities, their own internal alerts through healthcare systems, through consortiums such as ones that exist here in our region, of course, as well. And these can alert and prepare folks for the potential that outbreaks are occurring. Then, of course, as Dr. Pavlik has been mentioning too, the potential for syndromic surveillance signaling, and whether that is through monitoring means, whether that's through the BioWatch surveillance program as well too. So things certainly to think about. Dr. Pavlik, anything else that you want to bring up with regards to this? I don't also want to just talk alone here.
No, I think you for this one, I think you've nailed it on the head. I think, if for, like you mentioned, the syndromic surveillance signal, if this wasn't identified by that kind of first point of interaction with a healthcare provider, we may see this later in syndromic surveillance. And, we'd be able to kind of identify fever, rash, international travel, which would flag a concern for us, which would initiate kind of that additional public health follow-up if it wasn't caught kind of at the front end at a facility as well.
Great. Next slide, please. Just to tie this off, you can keep clicking through. So as Dr. Carrasco mentioned, the first concern and thinking is, if there is a concern for something, mask and isolate the patient, right? As Jill Morgan, who I think is on this call, will say, whatever that patient has, I don't want it, even if it's the common cold, right? So mask and isolate. There's no patient safety without staff safety. We think about implementing airborne precautions, something like measles, which travels through the air quite rapidly. Dr. Kumar spoke quite detailed, gave us a detailed explanation about the importance of, travel history, exposure history, clinical history, and temporal history as well. We want to, of course, as Dr. Pavlik mentioned, notify our public health professionals to coordinate testing, contact tracing, if it is needed as well, too. So let's move to the next scenario. And Dr. Pavlik, I'm going to give that to you to take the lead on, if that's okay.
Dr. Pavlik,
Doctors Harris and Pavlik, I'm going to just interrupt you for a second before you go to case number 2. Sure. There is a question in the chat, and I want to, honor questions that are coming up in the dialogue here. And I might ask Doctors Carrasco and Brewer to just give some thoughts about this. The question is discussing registration personnel, who are often the first point of contact when patients present for an emergency department visit or in some other clinical space, and what strategies there might be to increase awareness among that group, or how to better mitigate that before the patient gets to triage and someone might be prompted to ask questions from the electronic health record. Any insights?
Yeah, thanks, Alex. And, I think that we all have points of entry at our facilities where there are individuals who aren't necessarily the medical, trained personnel that are that initial point of contact. So it does take a little bit of work. They're not in the electronic medical record, as you noted, but there are ways to do that, outside the medical record. So that is through, having the information on a piece of paper where the individuals are asked to screen upon they present to like their primary care physician. I think other strategies also include screening individuals, and this happened, in 2014. But before you make an appointment, do you have these symptoms or have you traveled? Getting that information in advance. I think another area of opportunity is having individuals or those patients that are coming to your ambulatory care, to your emergency department, to any point of entry, having them self-identify, having signage up where it says, do you have a fever? Do you have a cough? Do you have these symptoms? Please mask, and then notify a healthcare worker. So they're prompted. There's this self-identification for them to also self-identify. Brooke, is there anything you would add?
Not too much. I think, when folks identify or are identified at the points of entry, making sure that your registration folks or your check-in staff have just the basic materials there available. They have, if you're not keeping your masks out, they have a mask to hand to the patient. They know the basic questions to ask. And if somebody does answer yes to having a symptom or self-identifies, then that staff member knows who to go and grab to help isolate that patient or not put them in the waiting room. So just like Sharon said in the chat, keep it very simple and have that person know who to ask for help.
No, thanks for fielding those questions. Let me turn it back to the presenters for scenario.
All right. So our second scenario, thinking about, a traveler who may present with severe respiratory illness. So this one is a 51-year-old visitor arrives in Atlanta, of course, to attend World Cup events. During triage at a local emergency department, the patient reports fever, cough, and an increasing shortness of breath. The patient recently had returned from Saudi Arabia 8 days ago, where while they were there, they attended a large gathering and they also visited several healthcare facilities because they were accompanying a family member who was receiving medical care. So here, we've got some concern of, are we thinking, possibility of MERS, from Saudi Arabia? As we know, as Dr. Harris mentioned, it's typically transmitted by camels. However, there is a risk if, persons do visit healthcare facilities while there, if they could have come in contact with someone who was ill in the healthcare facility, or, at this point in time, we don't know what was their family member necessarily receiving care for. So next slide. So, what are, the most important clues in this scenario? And I may ask Dr. Isaacoff if he may help me pick the best of our panelists who would be, good to kind of talk through, what you're thinking here, what questions you may be asking the particular patient themselves about their risk factors to help you guide, some of your next steps.
Appreciate the opportunity to be responsible for calling somebody out to answer these questions. Anybody willing before I
guess,
before
I could have asked
assign?
that first.
Oh, wow.
I mean, I can keep rolling if rather than put everybody in a spot in the interest of time. But I think in this one, the symptoms along with travel history, I guess, is the main thing. But especially for MERS, travel to Saudi Arabia would probably be the highest on my radar.
And Dr. Kumar, I would also add being around somebody who's been ill. Dr. Pavlik mentioned they'd been to multiple healthcare systems, escorting either, family, friends that were also ill. And if you are utilize Epic as your electronic medical record, you know that the questionnaire that is generated actually asks that question: have you been around somebody or exposed to somebody who is unwell? And they ask that for these specific reasons, because maybe you haven't traveled, maybe you didn't go to Saudi Arabia, but your friend or your family member did. And so that is an indirect exposure. That's that direct exposure, but not direct, linked to Saudi Arabia. So that's why we ask that question.
Thank you so much. Next slide. So I think as mentioned, looking at that travel history that's obtained, hopefully that there's a flag in your EMR system. And if not, I will pop in the chat our travel clinical assistant shortly so that you have the direct access to that resource that we have for Georgia. Also, mentioned that, they had increasing shortness of breath, possibility, requiring hospitalization at this point, that travel to an area with MERS transmission. And then, thinking about, of course, the healthcare provider had that awareness and training where they were aware of, again, that identify, isolate, and inform, and then those screening protocols as a part of the infection prevention. Next slide. So I think, as mentioned, always placing that patient in appropriate isolation right away, limiting some of those staff exposures and using the appropriate PPE. That inform process to inform public health and do that consultation. Sometimes travel alone is not the only factor that we look at. We really do need to think through one, the clinical picture, the travel is one piece, but then also what are the risk factors of travel? I just kind of want to bring it back to, thinking about even like loss of fever, just travel to one of those areas alone does not immediately make us think loss of fever. I know that's a whole nother disease, but just kind of thinking through that, we're looking at a variety of things, not only clinical picture, travel, and risk factors. They all are important to think through. I know we're fairly short on time. I'm not sure if we want to pause the scenarios here and we can turn it back to our, Dr. Isaacoff and team if there are other questions that we want to ask some of the members as well.
Yeah, thanks for that, Dr. Pavlik. The scenarios, I think, are very helpful to kind of demonstrate the importance of being vigilant for syndromes and having an understanding about how the travel history really contributes to diseases that are more geographically isolated, and that underscoring of principles that are described in the identify, isolate, and inform paradigm are very good. I'm going to bring to the attention of the audience, if they're not paying attention to the chat, some resources that were placed there, particularly the Georgia resource, Travel Clinical Assistant. Really helpful, I think, for frontline clinicians to be able to go to that resource if they have any questions about whether or not there's an outbreak of concern in a particular country that someone says that they've recently visited. That can be very, very helpful. There was a question also in the chat regarding lessons learned when trying to interact with someone who is speaking language, or English is not their primary language. So I think there's certainly, it's very important, to have the use of interpreters. I know as a clinician in the emergency department, actually having a phone number and on my phone that I can use on speed dial is fantastic for quickly getting a history from a patient. It also avoids the need to bring another person in the room that would potentially, be exposed if they have a communicable disease. But those interpreter services are really invaluable. Anybody else with a quick lesson learned on use of interpreter services when interacting with these patients, Sharon?
And not necessarily, Alex, working with interpreters, but I think even trying to identify even that step before, with the conversation and asking the questions, but that self-reporting, I think this is the importance of having good signage up that not only includes, do you have these symptoms, but also having them in like a pictogram or infographic type look so that regardless of the language an individual speaks, they recognize these symptoms, like a thermometer to identify somebody with a fever. There are certain images or pictures that you can draw from that really will help sort of ask those questions without asking them in every single language posted.
Yep, thanks for that. Dr. Wong, I see your hand up.
Yeah, thank you, Alex. I just want to add a little bit more to what Sharon also said is, something very important about lessons learned from like a personal perspective as well, that Cultural sensitivity is something that was, there are two things. Cultural sensitivity is one that I definitely have learned throughout the years. Whether or not, it is very useful sometimes to have a remote interpretation service and like getting the resources from your healthcare system. To have that on hand, like what Alex had mentioned, is a really quick and easy way to break some of those barriers sometimes. Another one is also understanding that sometimes additional equipment like an interpreter iPad or like a computer or a phone device can also require some additional decontamination and something that we need to look at as part of the process and protocols when you're looking at decontaminating or limiting the amount of equipment inside the room. Those are just a couple things that I've learned throughout the years doing this, and just a couple things to be aware of.
Yep, thanks for that, Esther. All right, we have 9 minutes left, probably with about 5 before the hour. We'll just go into some closing statements. But Ken Kick, thanks for joining from Kentucky. You have the floor.
Hey, Dr. Isaacoff, glad to be here. Hey, thinking about our other points of entry into the system, we've talked a lot about hospitals, signage, and what registration could do in the whole identify, isolate, and inform. When you're thinking about EMS, I think, they do a great job identifying. When it comes to isolating, now we're talking about PPE, so we need to make sure that, they're doing the right thing there. And then the identify or the inform part, they could really, give the hospitals a good heads up and say, hey, I got something kind of suspicious here. We may want to go straight to a room and not sit in the hallway and talk about this, or, go through triage or whatever. And then also thinking about our FQHCs and our clinics and our, the Kroger clinics that are inside stores, making sure that they have that information too, that when they have something suspicious walk through the door, that they have a place and a plan where they could immediately isolate. Just my thoughts on that.
Yeah, I couldn't agree with you more. I think those are really important points. I think this is where, having a simple paradigm, the identify, isolate, and inform paradigm is useful, because it can really be used, across all the disciplines, professions that are engaged in the delivery of healthcare, including the EMS community and, and all those clinicians that are working in out of hospital ambulatory care facilities. Sharon, I see your hand up.
Yeah, thank you. Great points, Ken. And again, just echoing why it's so critically important to a mask individual, because that will help do so much source control, regardless of the environment in which that patient presents. And, Ken, you brought up other kind of points of entry, and think about this from your healthcare, perspective. Don't forget about direct admits. That's another point of entry that oftentimes, is sort of not thought of. We think about the emergency department, we think about ambulatory care, we think about urgent care, but direct admits are another point of entry that, working with your bed control and that admission process, that those patients are potentially screened as well for symptoms and travel. So just don't want to forget about that.
Thanks for that, Sharon. I see a question in the chat regarding a procedure to notify EMS of a person under investigation. I'm going to maybe reframe the question the way I understand it, which is if there's somebody that's being monitored or known to be a suspected case of maybe a high consequence infectious disease, would EMS be alerted to that when they respond to that residence or to that individual? Is there anybody that wants to provide a quick answer to that? In short, there are some privacy concerns as it relates to how information is shared, but I think for safety of personnel, I'm almost certain, and Dr. Pavlik can tell me if I've got it wrong, that if they have an individual that they're monitoring for a high consequence infectious disease that develops signs and symptoms, then certainly anybody that they would ask to go and do an evaluation or help move that person to a place that they could be assessed, if that included the EMS personnel, they would be made aware of those risks and how to implement the right PPE, maybe even have a dedicated team do that movement.
Absolutely correct. And I mean, specific, at least for Georgia, if it was a high consequence pathogen of concern, then we would have a kind of designated team, which is our infectious disease transport network, who would be specifically contacted to be able to transport that patient from their home, is what I'm assuming, to a designated facility for us. So we would also reach out to the facility and EMS and work in collaboration to make sure that that person could get safely to the facility, and also that all of the healthcare providers are safe.
Yeah, I appreciate that. Thanks for the answer. With 5 minutes before, I'll acknowledge the question that was placed by Stephanie Payne about whether or not someone could refuse to wear a mask if they've been asked. They can refuse to wear a mask if they've been asked. We don't really have enough time to unpackage the response and, what public health powers might otherwise be brought to bear to influence them to do the right thing for the protection of others. But Sharon, you have your hand up, so maybe you do want to tackle that quickly.
I was trying to type it, but I couldn't type quite fast enough. Sorry, Stephanie. But I think to your point, Alex, right? The first thing, if a patient's going to refuse, and we saw this back in the pandemic, right? When patients would refuse to wear masks, the first thing is take care of yourself as the healthcare worker. So do try to at least cover your holes, as Joe Morgan would say, right? So that you're safe in that interaction. But then also try to educate that patient as to why you're trying to do that. You're trying to protect, their family, the community, the people around them. And that's why we're asking them to mask until we can get some more information or get them into a more private location where they can then unmask at that point.
Yeah, I appreciate that. Thank you. All right, as we run out of time, I just want to bring to your attention in the chat that SRDRS has worked together with partners, many of them on this call, to develop some primers for the World Cup operating period. I've placed an active link to that in the chat. Included in that is a biothreats primer that Dr. Harris was the lead author on, and others had the opportunity to review. It is among the resources that are on that webpage, so please take time to visit that. Let me now move to closing our session. Thank you to the speakers and the panelists for participating in this session. I think it's been an invaluable opportunity for sharing of information. We have upcoming echo sessions that you can see here on your screen, and Stephanie has put a link to register for those upcoming sessions. Let's hit the next slide. I'm off script now, Stephanie, so you have to follow me. Post-session poll coming up. Many of you noted that we posted the post-session poll in the pre-session query, but you'll recognize the questions here. So Stephanie's going to pop those questions, and let's see if we can. Oh, see now, I think that somebody who commented, "Hey, you put the post-session poll up. Now there's the pre-session poll. Consider a post-session poll." And as we might expect, we're starting to see responses that reflect that there was some sharing of knowledge here in this session, as I fully expected. I learned things here too. Among them, you got to keep an eye on that Dr. Harris. He might deliver a pop quiz when you least expect it. All right, and with that, we'll go to the next slide. There's your results for the post-session poll. But thank you for joining again today. There is an evaluation survey that we'd love for you to fill out. So go ahead and scan that QR code and let us know what you think. We have these sessions scheduled through the end of October, I think it is, right, Dr. Harris? And there's 2 per month. Some here are more anchored in SRDRS work, some more anchored in SCDP work. We think always relevant for our region's emergency preparedness. And we'd love to see you all join. Again, one more special thanks to the presenters who are very busy at this time, especially with World Cup operating period kind of happening now. And special thanks to the panelists for joining as well and staying engaged and answering questions. And we hope to see these panelists back for another session. All right, that brings us to the top of the hour. Thanks all. Have a great day.